Hi, my name is Sarah Spencer, and the abstract I'm presenting today is titled Retention of Patients with Opioid Use Disorder Who Use Methamphetamine After Instituting Low Threshold Care in a Rural Alaskan OBOT. I have no financial conflicts of interest to disclose. I'm the physician for the OBOT program at Ninilchik Traditional Council's Community Clinic. I'm a board certified in family and addiction medicine, and I also volunteer as the medical director of the local rural syringe access program in Homer, Alaska. Our rural tribal clinic is in the village of Ninilchik, Alaska, population 800, which is 35 miles from our nearest pharmacy or hospital, which is in Homer. Our local hospital service area serves 13,000 people, which are spread over 9,000 square miles. Some of the unique populations that we serve are 3 roadless Native Alaskan villages across the bay, Seldovia, Port Graham, and Nanwalik. And we do have patients in our program who live in those Native Alaskan villages, and they have to come to their appointments via ferry or plane or through telemedicine. And then there are also 4 remote Russian Old Believer villages, some of which are inaccessible by road in poor weather conditions. We also serve patients who work on commercial fishing boats and on the North Slope oil fields who may spend 2 months or longer in remote areas with no access to medical care or pharmacies. I am the only addiction medicine specialist on the peninsula, and the next nearest is 200 miles away in Anchorage, which is also where the nearest OTP is. Stimulant use has been increasing in our patient population. Between 2016 and 2020, the percentage of patients admitted to our OBOT with comorbid opioid and methamphetamine use disorder has increased from 23 to 35%. And this past year, we saw a further increase to 45%. Methamphetamine-related deaths have tripled in Alaska in the last 3 years, and combining stimulants with opioids increases overdose risks. Patients who use methamphetamines have been shown to have lower retention and treatment in OBOT programs, but low threshold care can increase retention in high-risk patients. Unfortunately, there's little literature about low threshold care in rural areas. Our clinic was fortunate to receive grants in 2018 to expand access to care, and we seized this opportunity to develop a low threshold care track in our program. We wanted to know, would retention of patients with OUD who use methamphetamine increase after we added low threshold services to our rural OBOT? Some of the ways our clinic increased access to care is by offering same-day walk-in appointments, telemedicine, and sometimes home visits, flexible dosing of medication, including off-label starts of extended release buprenorphine with sometimes single-day dosing of sublingual buprenorphine. We offer primary medical care, hepatitis C treatment for patients who are actively using IV drugs, remote video directly observed therapy, same-day co-located behavioral health, and we never discharge patients for ongoing drug use. Our peer support case management specialists are available to patients after hours by cell phone and by text messaging. They check in with patients at their medical appointments. They arrange transportations. They help get them gas cards or give them rides. Sometimes they even deliver their prescriptions if needed. They assist patients with completing applications to treatment or for social services, and they provide outreach and arrange rapid intake from the emergency room and from the jail. They volunteer frequently at the local syringe access program and have developed trusted relationships within our local community of people who use drugs. We did a retrospective analysis of retention and treatment for patients with comorbid amphetamine and opioid use disorder. We reviewed EMR data for patients admitted 2 years prior to and 2 years after adding low threshold services in the spring of 2018 to identify patients with amphetamine use disorder and utilize PDMP data to compare the number of weeks of buprenorphine therapy between the 2 groups. We also compared the subgroups within the low threshold group to see if retention was associated with factors such as IV drug use, criminal justice or child services involvement, behavioral health engagement, peer support, housing status, or formulation of buprenorphine. Our two cohorts, treatment as usual and low threshold, had similar characteristics. The average age was about 35, gender distribution was about 50-50, and they were about 80% Caucasian and 20% Alaska Native. The groups had similar incidences of IV drug use and housing insecurity. We have seen an increase in behavioral health utilization and in referrals from criminal justice. Our analysis revealed that patients who use methamphetamine stayed in treatment on average 2.5 times or 14 weeks longer after the introduction of low threshold care. So this was very good news for us to see. The largest increase in retention was seen in patients who utilized extended release monthly buprenorphine with an average buprenorphine length of therapy of nearly 32 weeks, compared to 13 weeks for the sublingual dosing low threshold group and 9 weeks for the sublingual dosing treatment as usual group. This wasn't too surprising to us given the major transportation barriers to attending frequent appointments and filling frequent prescriptions for sublingual buprenorphine. Fishermen and other remote workers especially appreciate the long-acting effects of extended release buprenorphine. Peer support utilization was also associated with an increased treatment duration of 1.7 times or 12 weeks longer. Our threshold for identifying peer support utilization was low and included patients who access peer support at least once monthly via text or phone conversation or in-person contact. Other variables, including behavioral health utilization, IV drug use, housing status, criminal justice, child protective service involvement, were not associated with significant differences in retention in either group. The main weakness of our data analysis is our small patient population, and this data is from a single prescriber, so clearly individual prescribing practices may vary. Also, some of our changes occurred gradually over time in our clinic, so in some ways the May 2018 date is somewhat arbitrary. Future projects, we would like to collaborate with other rural sites to pool data to make it more meaningful. We want to start a contingency management program to address stimulant use, and we would like to enhance our mobile services and considering starting a mobile rural OTP. We would love for you to reach out to us with any questions. And I definitely want to thank my case manager and peer support specialist, Annette Hubbard. Our clinic couldn't possibly operate without her and all her hard work and expertise.